Hi everyone in Seoul, Korea. I'm currently on a cruise ship with my ferry. That's why you can see it's kind of a bit rough out there. Thank you for the invitation. I'd like to particularly thank Soo-jong Kim for inviting me to speak, and I'd like to congratulate the Korean Academy of Cranioorofacial Growth Guidance for their 19th symposium. I believe when I've spoken once before at the IFUNA meetings, we like to thank in particular Professor John Mew for his contribution to orthodontic education, in particular for teaching people like myself the benefits of treating early and getting that maxilla in the right position. So I think the formal greeting in Korea is 안녕하세요. I wish I could have been there with you, but unfortunately there was a conflict. So I'm here with a great group of doctors on our way to Iceland for a cruise. Can you show the doctors in the thing, or? It's wide enough. Great. So I'd also like to keep it as a Korean theme thank very much my good friend and colleague, Professor Won Moon, who has made greatest contribution, as far as I'm concerned, to orthodontics and craniofacial growth guidance with his development of the MSE technique, which initially Won called maxillary skeletal expansion. But what I want to talk about today is what it really does, which is mid-face skeletal development, right? This paper, I'm happy to send to anyone who is in the Korean Academy and would like to read more. And the cases that I'm going to show are based on this philosophy by Dr. Moon. And basically what it comes down to is that we all understand that a good-looking face is going to be a face where it's not just a transverse dimension, where the maxilla has enough room for the teeth. And we all know how to deal with those sutures. We're talking about a good-looking face where the maxilla is forward in the right position to the cranial base. So I'm being asked to talk about skeletal class 3, and in my classification system, this is called a skeletal 3A, or maxillary midface deficiency. The controversial ending of my lecture will be to discuss what I could potentially do for an adult patient using this technique. So I think you've all heard of the controversy that's happened around the world and the number of lawsuits related to the FAGA appliance. FAGA stands for Fixed Anterior Growth Guidance Appliance, and unfortunately there's been a lot of negative literature based on patients who know that they have maxillary deficiency. I believe Professor Mew's son, John, may also be in the audience. John, congratulations for all you've done on educating the community on the importance of tongue posture and the mewing effect, which I believe has got 1 billion followers. But I think what I want to discuss towards the end of the lecture, the controversial part of my lecture, is can we, in a non-growing individual, without surgery, move their maxilla forward? I think we'll call that the holy grail in orthodontics. And I would have to say, after following the Won Moon protocol rigidly, I'm now seeing those success rates. And with the FAGA appliance, and I tried quite a few of those, the concept was we'd have posterior anchorage and orthopedic forces in the pre-maxilla to move the jaw forward. But unfortunately, like many people, I saw many teeth being pushed out of the labial plate, etc., etc. Does my patient want to put their hand up and have a Lefort 1 osteotomy or a high Lefort 3? The answer is no. Do my patients want a good-looking face and follow the philosophy of Dr. Mew, where we have forward growth guidance? Yes. How do they want to do that? They want to do that orthopedically. So in an ideal world, all the patients would show up in mixed dentition where we can achieve these orthopedic results. But in the real world, we're having adult patients who are coming wanting these results and wanting them non-surgically. So that's what I thought I'd talk about in this 30 minutes that the Academy has kindly given me. So I'm very proud of my two leading clinicians who perform MSE with me in Australia. We are close to nearly 600 finished cases now. And I've made the conscious decision that I can get better outcomes using MSE face masks in mixed dentition than I ever did using the McNamara protocol. So when I trained in classical orthodontics, the protocol we used for mid-face deficiency was a bonded hyrax. We had hooks and we used a standard Delaire face mask. What I was seeing was movement forward, but very minimal compared to what I see with MSE. And Won Moon has explained to me why, and I want to try and share that with you. But again, I would like anyone who is watching here on the cruise or in Seoul to register to listen to Won Moon wherever he is. He's a wonderful clinician. He's a nice guy, amazing academic, and does courses all around the world. On the cruise here, we have a lot of Australian doctors, and I believe Dr. Moon will be here in August. So if people wish to make the trip to see him, you'll learn more about this exciting technique. So thank you to Won Moon. Thank you to my two lead orthodontists. So transversely, we all know that suture, or those three sutures, the mid-palatal, the cruciate suture, and the pre-maxillary suture can be developed at an early age. And that gives us beautiful development of the arch, forward growth. I love Dr. Mew's BioBlock Stage 1 appliance because it gives me those amazing results, okay? Now, what happens if the patient needs more than development? What happens if the patient has a maxillary constriction and a retrognathic maxilla? So then we need to use face mask therapy. And my problem with face mask therapy to bonded hyrax is that a lot of my orthopedic forces go through teeth. So I'm not getting as much skeletal change. With the Won Moon technique, I'm doing three benefits. Number one is I'm loosening those sutures and I'm allowing natural growth and development to occur for a young child. Number two, you'll see the biggest resistance to maxillary expansion and forward growth in the anatomy slides that Won has given me. And you will see that if you really want to get that maxilla forward, you need to disrupt those sutures. And you can't do that with a bonded hyrax. There's many what's called skeletal anchors on the market. Dr. Benedict Wilmers, University of Dusseldorf, has developed this whole Benny plate system, and it works well. But again, I want to compare and contrast the positioning of his screws, which are more the palatal rugae region, to where Won Moon has put his screws, and see the disruption we get on the sutures. So in my practice, where do I use this technique the most? In mid-face deficient patients. Children, class 3As, adults who do not wish to undertake orthognathic surgery. What do I see about this technique that's vastly beneficial compared to, say, what I see with Benedict Wilmer's technique or McNamara's bonded hyrax technique? I'm seeing a huge improvement in the airway. And that's because of the bicortical anchorage on the nasal floor. So please don't let anyone tell you that sutures eventually ossify. That's what I was taught in dental school and in orthodontic school. I now know that sutures remodel. And the paper I'd like you to read, again, I'm happy to send you a copy of this, is by Dr. Kumar et al. That talks about maxillary expansion. But I'm after more than maxillary expansion in my patients. I'm after maxillary development. So I don't like using the word expand, I like using the word develop. I want to widen and protract. And we talk about circummaxillary sutures. Now, when you're young, those sutures are wide open, but as you're getting older, they need a little bit more emphasis to remodel. Hence why the MSC technique works well in that adolescent and particularly in the older age group. But why do I still use it in mixed dentition? Because in the traditional face mask, as I'm doing my orthopedics, I'm getting the maxilla forward, but I'm also seeing flaring of the upper incisors, which is more orthodontics for me later on. I'm also seeing in these cases with traditional face mask therapy, lower face height increase. The chin cup tends to rotate the mandible backward. In the Won Moon cases, and in the paper that I'm going to discuss with you, he's shown the opposite. Uprighting of the incisors and no change in the face height. So it's a win-win orthopedically for me. And obviously we have a very high volume practice. We now have 9 orthodontic clinics in Sydney, Australia, in Australia, in Brisbane, in Melbourne, and in Sydney. And on average, we're starting 6,000 new cases a year. It's a very big setup. So I want efficiency, I want predictability. My philosophy is still the same: early treatment, minimal extractions, improving facial balance. The things that the Muse have talked about for many years, right? I'm big on fixing airway. But ultimately, I need a technique that's going to work for the patient that's missed that opportunity and still has mid-face deficiency. So when you look at the mid-palatal suture and the diagrams that we are classically shown in dental school, we kind of think it's two-dimensional. But if you pick up your skull and you look at the diagrams, you'll then see that it really is a true 3D suture. And what prevents the good expansion is in this region, not what we would classically look at in the palate. And we call this the zygomatic buttress bone. And even a max-fac surgeon doing a Lefort can't get in that area because of the zygomatic in the way. But with the Won Moon technique of MSC, we're able to open up that suture, develop it in a child, and actually disrupt it in an adult. Exciting times. So look at you. I don't want to spend too much time on anatomy. In the short 30 minutes we have, I want to show you some cases. But ultimately, look at your sphenomaxillary junction. Understand that the maxilla grows downward and forward. I love quoting chapter 4 of the textbook, Hans and Enlow. And Dr. Hans has put some great YouTube videos now to explain this. That chapter is called Growth of the Nasomaxillary Complex. And that means if you breathe through your nose properly, unobstructed, and you have good tongue position, what causes stimulation of the sutures of the maxilla is what we call intramembranous ossification. So the tongue hitting the palate, the sinuses developing down, the muzzle effect, and your maxilla grows forward naturally. So why do we see people who don't have natural maxillary growth in a forward direction? Normally airway, normally poor tongue posture. So sphenomaxillary junction is important when we're talking about forward growth. The sutures we were discussing for the development don't look at this aspect of care. So it's important if you're going to be a craniofacial biologist, if you're going to undertake dentofacial orthopedics, you look at that. So let's talk class 3 in basic terms. Class 3, majority of class 3s, research by Moyers, has shown are maxillary deficient. Less are mandibular excess. Mandibular excess cases, there's not a lot you can do. And in my book, I tend to watch and wait, and we can use techniques like the John Lynn technique with TADS, where you have orthodontic surgical options. I use the Hugo de Klerk technique of bollards, but this lecture is about the more common class 3, which is maxillary deficiency. And our options are growth modification, surgical orthodontics, or what we call non-surgical orthodontic compensation. What does that mean? It means that I went to dental school, I would just wait for adult dentition, no orthopedics, And in a class 3 case, I might take out lower premolars, right? Or sometimes I would do upper 5s, lower 4s. It was all camouflaging the problem. So if we look at what's happening and we look at the timing, we know that those nasomaxillary complex is a key part in determining the size of the upper airway. And the earlier you do that, the better. So these are the sutures that we have to disrupt if we're moving the jaw forward. In nature, with good nasal breathing, with good tongue posture, bone is deposited not in front of the maxilla. It's not remodeling like a tooth moving. Bone is deposited at the back in that same spheno-maxillary junction, so that we have the frontomaxillary suture, the zygomatic temporal suture, the zygomatic maxillary suture, the pterygopalatine suture, all being pulled forward. So if we don't have that naturally, we've got to disrupt those sutures. And the way to do that is get your forces into the bone, not the teeth. No amount of tooth movement or forces on teeth is going to have any effect on those sutures. And that's an important point. So if we look at this case, the way I would normally treat it would be this McNamara's bonded hyrax. I would use the protocol that was first described by Dr. Franke of the famous CVM fame. And Franke's protocol is alt-ramic. And what that allows us to do is overcorrect this class 3 midface deficiency into a class 2 before we put it into a Frankel to retain. And we do get good results in that regard, but when you compare and contrast what are some of the complications are listed here as described by Won Moon, and they are, so this is classical face mask with RPE, okay? Bonded hyrax. You get difficulty in a high angle case. You get buccal tipping of those posterior teeth, which further increases the vertical dimension, and you get flaring of the upper anteriors. So we all know what we want. We want Andrew's 6 keys of occlusion. We want a good interincisal angle, but what do we really see in class 3? We see nature's compensation. Today, with this group of lovely students, we've seen a lot of class 3Bs where the lowers are retroclined, right, doctors? Right? But when you see the class 3 with the maxilla back, the classic compensation is the flaring of the upper. So if you then use a technique which is going to further flare the upper, you've got more work. Does that all make sense? Right? So if we look at this little girl, she is classically mid-face deficient class 3. And when I visited Korea, when I've been there maybe 20 times now, and by the way, I'm already missing the Korean food on this cruise ship. We're having Scandinavian cuisine, which I should have packed my kimchi to take on the cruise, right? The concept in Korea, a lot of mid-face deficiency. So if there's one place you're going to do a lot of these cases, it's in Seoul. So what do we see in these class 3s? Transverse problems, we can resolve those really easily. But bringing the maxilla forward is more difficult. And add to the complexity a vertical grower. And we saw a case today, correct doctors, that was maxillary midface deficient, transverse problem, and the vertical grower. And I said to you, that's a tough case to treat. But if you use the right protocols, we're trying to get the maxilla forward. How do we get the maxilla forward? Look at the research of Kokich and Shapiro before the advent of TADS. They took out 2 deciduous canines, they took out the nerve, they denuded the periodontal ligament, they put those back into the maxilla and they let them ankylose. So they became skeletal anchors. And then they used their reversible face mask to those teeth, and it really got magnificent AP changes. And that's why we know skeletal anchorage works, right? So now we are able to bring that girl's maxilla forward and not have an increase in her face height and not have flaring of the upper incisors using the Won Moon technique. So this is a case where a bonded hyrax has been used, not the MSE technique, And yes, there has been an improvement of the crossbite, but can everyone see the flaring of the incisors, right? And can everyone see what was a deep bite and is now a open bite because of the backward rotation of the mandible? You can see it here cephalometrically, right? Antigonial notch, as described by Bjork and Skeeler. Lower face height increases. So really, we haven't achieved the best that we can do. And if we reassess cephalometrically, we see increase in the lower face height. We look at the A and B difference, and that's good. But if we look at the upper incisors, it started at 101 as nature's composition and have really flared forward. So that's a red flag. So is the lower face height increase and the vertical axis. So if we scour the literature to look at what has been published when it comes to orthodontic and orthopedic changes in these class 3 subjects, we look at this paper in the European Journal of Orthodontics, where they discuss managing developing class 3 malocclusions with RPE and maxillary protraction, bonded hyrax, reversible face mask, favorable results such as vertical and sagittal displacement of A point. But what I'm saying to you is that it's not just the A point we're looking at, it's the face height and the flaring of the incisor teeth. Patrick Turley has probably been the master of this technique using his delayed protraction face mask therapy. And in this paper, published in the American Journal of Orthodontics in 1999, he talked about the things that we don't want to see. And that is going to be the downward and backward rotation of the maxilla and the clockwise rotation of the mandible. So maxillary teeth move forward while lower incisors retruded. So the dental compensation involved. This is the classic RPE with reverse pull pads. This is the classic Delaire face mask. So now what happens if we look at MSE with the same face mask? The only difference here, we're placing 4 screws in the palate and we are monitoring the changes. I no longer use hand x-rays thanks to the work of Frankie Barchetti-McNamara. We're using this vertebrae. Where's the best time to do this? Obviously, the best time is going to be during maximum growth of the maxilla, CVM 1 to 2. But if you miss that boat, you can still disrupt the sutures with skeletal anchorage. That's the exciting part of what we can now do as modern day orthodontists. So using MSE with the reverse pull hooks, and then camouflage treatment. We now look at the case, very good changes of A point, forward growth, not backward rotation. Big improvement in the position of the maxilla. If we look at the upper incisors, which in the last case showed flaring, we start at 116 and we reduce it to 95. If we look at the face height, it hasn't changed. So this is what I'm seeing with the MSE technique and face masks in growing individuals. Now, when we talk class 3, the orthodontics get that because no one argues that a mid-face deficient class 3A needs this treatment. The controversy arises when I start talking about class 2 children who also need their maxilla brought forward. Why? Because then we know where to position the mandible. So if you're class 1, class 2, or class 3, and you have maxillary deficiency, I still believe this technique works well. And then, of course, you finish in your standard fixed appliance therapy. So 2 cases that have both ended up with good outcomes, but this case, an uprighting of the incisor and a maintenance of the lower face height. Now, as I said, I will end this 30 minutes by talking about what we do in adults. Obviously, adults are less predictable treatment modalities. And if an adult wants their maxilla brought forward, we have to use a special type of MSE, and that is either by cortical punctures and or modified surgical options. And I base that on my CBCT. And I'll share a great article that will show you how to look at the CBCT and determine what type of MSE you need. MSE is not just an appliance. It's a philosophy, it's a technique, and honestly, if you can see Won Moon present this information in a summary, it will make a lot more sense. So we're using 3D technology now to determine where to place our anchorage screws in an adult patient. So we send to the lab in Korea. I think it's called Korean Biomaterials. This data, CBCT, digital scan, and from that we can look at the position. I've got to the stage now in our practice where I'm beginning to use nasal endoscope to make sure that these screws actually do go in the nasal floor. Now, many people might say, oh my God, isn't that dangerous? I think anyone who's done a sinus lift will realize that that remodels very quickly. But it makes sure that I actually have bicortical anchorage in all 4 screws. And that's very important if I'm going to see the results that we're seeing today. So 3D planning, just like Benedict Wilmers now has his TADMAN that allows the lab to give you your surgical guide to place it and the appliance is manufactured. The digital workflow for MSE is also magnificent. And some of the recent papers that are coming out on MSE are really showing the big improvement in airway. So what I'm saying to you, yes, we all can get a good looking face and room for the canines, but what about breathing? This is the secret. So if I have a child that has mid-face deficiency and airway problems, then this is my go-to technique as opposed to the more standard. Now, I started not doing any orthopedics. Most of my cases were extraction-based. Then I went to a situation where we're using our standard expanders. The level of expansion is occurring at the teeth, so lots of tipping. So you imagine my expansion was like this. For airway, my expansion with MSE is like that, right? Okay, so I'm going to conclude my short lecture and I'm going to learn how to say goodbye in Korean. I'm cheating here because I have a Korean doctor on this cruise who brought her own kimchi. That's why I was saying it's great to see. Okay, so if you're comparing MSE with traditional RPE, what you're really seeing is number one, expansion with minimal dental tipping. More skeletal expansion, more control of the vertical dimension. And I'll go back to Won Moon's paper with his conclusions, which are pretty amazing. But this is the big improvement, the improvement in the airway. When we start looking at 3D mapping, this is in adult patients. We're actually seeing true improvement in the mid-face. Why? Because we're disrupting those sutures, which no other technique can really achieve. So you're helping airway, you're getting more skeletal change, less dental. So this is the paper that I'll end my lecture with. Mid-palatal suture maturation, a classification method for timing of expansion. So the benefit of CBCT, which is through here, the palate, allows me to see what type of suture we have. And basically in this paper by, now I hope I'm saying this correct, Dr. Sevendez and Dr. Frankie et al., we are seeing 4 stages of the suture. This to me is a surgical case still. This is an easy case, and this is where I'm getting my best bang for my dollar with MSE. as we go here, I have some cortical punctures to help. So what happens in my practice for the older individual, I tell them, let's place the MSE and let's disrupt the suture. And if I see bending and I'm not getting the split, then my surgeon takes over. They've already consulted with the surgeon, okay? So the more brachyfacial the individual, so a male 35 or older brachyfacial, I'm not promising this split. But I'm consulting them with my MaxFac surgeon. So the concept is in this paper to look at the suture to plan the decision. But even Won Moon has shown that if you look at that paper as reliable parameters between conventional and surgical assisted RME, it doesn't really discuss the new world, which will be MSE. So I would end by quoting Won Moon's paper on his conclusions of mid-face protraction and comparing it with traditional. And that conclusion is combining face mask and MSE results in skeletal protraction even in mature patients, stimulating distraction-like movement, and gives a hope of discovering a novel, non-surgical treatment modality for these class 3 adults. With children, it causes expansion of the entire midface, disrupting all the pre-maxillary sutures. And when you combine it with face masks, you see almost negligible vertical side effects and flaring of the incisors. So this paper, published in Seminars in Orthodontics 2018, I'm happy to send to people. And with that, I will say, Gemsa Hubnida. Thank you.